I'd now like to invite Dr. John Auerbach, who's the president and CEO of Trust for America's Health, and his esteemed panel to come up and join me on stage here. Let me just say for a moment, you have the bios in your app, so I'm not going to read the biographies, but I just have to say John is one of these Renaissance men who has served public health in so many different areas, and I'm just pleased to have him at the helm of Trust for America's Health because they are doing so much in Washington to help us craft policies and have public health have a voice at tables that we are not always invited to. So, John, thank you for joining us today, and I'm going to let you introduce your panel.
Good morning. It is not a good thing to follow the Surgeon General. Dr. Adams, you set the bar way too high for us. What we're going to be exploring on this panel relates to the issues that the Surgeon General was talking about, and we've been hearing from Mary, we've been hearing from Mr. Talbot, we've been hearing from Dr. Smith, and that is, this is a complex issue. There are no simple solutions. There are no one step, if taken, that will solve the problem. We're talking about an epidemic that's related to fundamental underlying causes that relate to poverty and homelessness. They relate to racism and discrimination. They relate to trauma that people have experienced in childhood and as adults, and they relate to inappropriate prescribing as well as distribution of illicit drugs. This is complicated. And so part of the challenge in responding to an epidemic that's this complicated is understanding how we can work across sectors, as the Surgeon General was just saying. So the purpose of this panel will be sharing with you some of those cross-sector activities that are taking place around the country, and to give you a sense of what the successes have been, what the challenges have been, what the lessons have been in building important, necessary partnerships. You'll be hearing from my esteemed panelists who represent multiple sectors themselves, and they'll be talking to you about the work that they're doing in their sector and with others. And they come from across the country, from the East Coast, from the West Coast, from the heartland of the U.S. Even though this is an exciting topic and you'll be hearing some exciting things, I'm here to tell you this will be a frustrating panel because we only have an hour. And so what you'll feel like is you're getting a taste of what's possible, but not an opportunity to dive deep enough into each one of the examples that you'll be hearing. So do look for the panelists during the break. Do look for them over lunch. And a number of them will be speaking later in the day as well. What we're going to do in terms of the format is have a discussion, and rather than a speech from each one of the individuals. We're going to be asking some questions of the panelists, and after doing that for a certain period of time, then we're going to be opening up the discussion for you. So please, as the discussion proceeds, think about the questions that you want to ask. Think about the examples from your own work that you want to share. That said, I'm going to ask both you, as I've asked the panelists, to really be concise and brief in your comments, because again, this is a full day, a lot's going on, we only have an hour for this discussion. So in order to save time, I'm not going to introduce the panelists, I'm going to ask them to introduce themselves. And I'm going to ask them to introduce themselves and take a minute or two to explain the work that they're doing. After they lay that basis, then we're going to go more into depth into the specifics of what they've explained. So let me start by passing the working microphone to Dr. Monica Bharel.
Thank you, John. Good morning, everyone. It's wonderful to be here with you all today for this extremely important event that the Surgeon General laid out for us so nicely about how we do this work to address the current opioid epidemic. My name is Monica Bharel. I'm the Commissioner of the Massachusetts Department of Public Health. I am also a general internist who practiced primary care for over 20 years with individuals in multiple settings, but always faced with vulnerable situations where the social determinants of health that affect all of our opportunities for health really impacted their care. And one thing that always stuck with me in my clinical care and my health policy work was how much the behavioral health system, both for mental illness and substance use disorder, did not work for my patients. So when I came to the Department of Public Health in 2015, I was honored to work with our governor, whose #1 health priority is addressing this current opioid epidemic, devastating for us in Massachusetts, and implementation of that plan is being largely done through the Department of Public Health. What's most exciting about this time around, right, because there have been other opiate epidemics and other addiction epidemics before, is that we are looking at it through a public health lens and really working closely across sectors with our criminal justice colleagues, with education colleagues, with healthcare, public health, community colleagues. And we'll have more time to talk. I want to just bounce off of one thing that the Surgeon General said, talking about partnerships with healthcare. Massachusetts was, in fact, the first state to do a voluntary collaboration with our 4 medical schools and then all prescribers to include opiate education mandatorily for every graduating prescriber. That's over 8,500 individuals across Massachusetts. And that was a collaboration with the Department of Health, our governor's office, and the medical schools. So one example of a collaboration. And now, in fact, this year is the first year we've graduated from all 4 medical schools in Massachusetts, data waiver-ready medical students. So I'll stop at that now. Thank you. All right.
I think you're going to be doing a lot. Oh, thanks. Yes. Ms.
Good
Martin.
morning. Still on the East Coast. My name is Rosemarie Martin. I am an assistant professor in the School of Public Health at Brown University. My training is as a psychologist in methods in epidemiology, not a clinical person whatsoever. I'm an academic by training. I am an NIH-funded researcher 100%. So what that means is that I do a lot of randomized clinical control trials, and for anyone who knows that field will know that that means I conduct RCTs of medications and behavioral treatments. And sometime 5 to 10 years from when I start my trials, those trials will be published in journals that probably none of you in the room will read. And then maybe 10 years after that, there'll be some implementation and some dissemination around what we found out 15 to 20 years earlier. So while that's a really kind of exciting work to do. More recently, because of my background, I was involved with some research that was going on in our correctional system. And in 2015, the governor of Rhode Island convened a task force around the opioid epidemic. There were 4 pillars to that, and it was treatment, rescue, recovery, and prevention. And one of the areas that we identified in Rhode Island that really needed some attention was our correctional system. We know that among prisoners who are leaving corrections, the risk of dying in the 2 weeks following release from incarceration, 126 times that the general population. 126 times 2 weeks after release. Risk of overdose death, 40 times that of the general population. So our governor appropriated, from our general fund, we appropriated $2 million to do a medication-assisted treatment expansion in our correctional system. So the money was appropriated, and the School of Public Health came in as an academic partner to the Department of Health and to the Department of Corrections. And so I have the dubious distinction of working with the Department of Corrections in this endeavor. And we have a few sectors. We have our Department of Health, we have our Department of Behavioral Health, we've got the Department of Corrections, and the whole public safety from Department of Corrections, and also law enforcement, some of the local law enforcement agencies. It is a very interesting place to be, and probably the most satisfying work that I've done in my 30 years doing research. Because what we do today makes a difference today. And it's actually changing the lives and the health outcomes of individuals, but it's also changing the culture within the correctional system. And I'll be able to speak more to that after. But it truly is a cross-sector collaboration where there were many barriers and challenges, where we had to get buy-in from all of the stakeholders, and it was not easy.
My name is Jernejcic. I've spent 20 years practicing as a primary care physician and an emergency medicine physician. I'm not an addiction medicine physician. I'm not a pain medicine physician. But I have, just as our other presenter said, really seen how our system oftentimes fails patients and how they get into the situations that they're in. I'm also vice president for clinical integration at University Hospitals, a large hospital system in the greater Cleveland area, and was asked a little over 2 years ago to take that position, which leads quality and integrating quality across our system, to help address where we were in the crisis of the opioid crisis, to help lead our response across the system, not just in our ORs, our EDs, our floors, but out in our ambulatory world, and to develop a comprehensive plan to lead that. We did that, and I'm very proud of the work that we did, but to Dr. Adams' presentation today, I think we realized that we got to a point where we couldn't do any more on our own. There was a lot of work to be done, but we had to do partnerships, and we had to set up partnerships. And I then really the next iteration, and I think what we really want to talk about a lot today here is we, I believe, have a very unique consortium across the city where 5 healthcare systems, Cleveland Clinic, University Hospitals, our VA partners, our county hospital, and one of our charity hospitals have come together as a consortium. We were all doing great work on the opioid crisis, but we were doing much better work when we were sharing our projects together, raising each other, sharing best practices, challenging each other. And I can guarantee you, we are fierce competitors on most days and nights, but to come together to the table and really share and partner has been absolutely phenomenal for ourselves. I've learned a lot, we've shared a lot, but I believe our community has really benefited. So we'll look forward to talking about that today.
So I work with a project called the Law Enforcement Assisted Diversion Project, which was implemented as a pilot project in Seattle back in October of 2011. It is now no longer a pilot project. It is fully evidence-based at this point. But what law enforcement assisted diversion, or LEAD, is it enables officers at the point of contact on the street to make a diversion to community-based harm reduction case management. So rather than going into the criminal justice system, people are immediately diverted into social work and public health. And LEAD grew out of 2 specific things in Seattle, one of which was massive racial disparity in the criminal justice system, the second of which was that no amount of policing was stopping the drug trade. And we realized that the status quo was just completely broken and that there was a need to move on from there. And so we started with 3 specific questions, one of which was, can we make arrest the strategy of last resort for police? Can we transform what is almost uniformly a negative experience, getting handcuffed and taken to jail, and change that into something that is positive, and positive not just for the individual, but for the police and for the community. And the icing on that cake would be, what if this is actually cheaper than what we're doing now? So 8 years later, I can tell you we've made arrest the strategy of last resort. It is phenomenally better for the individuals and for the community, and it is so much cheaper, following Dr. Adams' point.
So, one of the things that I think in doing this work, people are really looking for is seeing something work, seeing change, seeing something that isn't just, it's a good policy in place, but we're really not going to know for years whether or not it's beginning to make a difference. And I know each of you have had experiences that really illustrate there is success that's possible. It is possible to actually put something in place and see in a relatively short amount of time significant changes that are going to have an impact. So maybe, I know you all have had multiple ones, but maybe I'd ask each of you to just highlight a specific achievement, an indicator of success that's going to make a difference, and give us the specifics on that either numerical or qualitative information that it's making a big difference. And Dr. Bharel, I'm going to hand this back to you again and ask you to start. I know you've got a lot of sectors you've worked in. If you would maybe just pick out one of those and share that experience.
Thank you, John. So when we talk about success, we have to be able to measure the outcomes. And in Massachusetts, we have been devastated with this opioid epidemic taking over 2,000 individuals a year, right? So our death rate is about 2,000. And we saw a soaring increase from about 2012 until 2016. That rapid increase was much driven, in the deaths, was much driven by fentanyl. And that was our call to action. And part of the reason it was our call to action, many of you who worked during the HIV, the beginning of the HIV epidemic, is we hadn't seen that rapid of an increase in deaths from any single disease since HIV pre-AZT. So it was really a call to action for all of us. So really from all of this cross-sector work that we've done, the most important outcome is that we are finally, in the last 2 years, seeing a leveling off and a decrease in that death rate. So we have seen a leveling off, and that's been very important to us. We still have a lot of work ahead of us, but we're starting to see this decline, which I hope will lead to our overall decrease. Thank you. It's a very important indicator. But one of our most important, so the piece that I'll choose to talk about is public-private partnerships as a sector. And I want to base that on the data work that we did. So in this space of addiction, there's lots of work that's happened before. Many of us know from the research world, there's never been enough research. Much of it is related to stigma and not seeing this as the medical disease that it is. So in the beginning of this work in 2015, we put together a public health data warehouse, which was a first in Massachusetts. We linked at an individual level information basically across these sectors. So it included for the first time linking data from mental health, from substance use, death, birth data, pregnancy data, claims data, and criminal justice data all together to be able to answer specific questions. And the way we did it, having also been in academics, was we flipped the usual relationship where a researcher has a question and a grant, say from the NIH, and comes to look at our data, and we said, we have this database, and we want to answer questions that will be able to impact our current programming and policies. We will tell you the list of questions that we have and ask you to help us donate your time. So we had academic centers, we have private organizations, we had partners in business donate the data analytics and other personnel to answer the questions we needed to answer in order to do the opioid-based work. And that, with no additional funding, is how we were able to begin to answer questions like that helped us with our programming and policy, such as mandated use of the prescription monitoring program, 7-day limit on prescriptions when we were seeing where those highest risk groups were. And one of the most important pieces for me personally has been the work that we've been able to do with vulnerable populations. So for the first time, we have mapped out specifically, quantified, who is at highest risk for opioid overdoses and deaths. And that includes in Massachusetts, as we were seeing those death rates go down, we unfortunately were seeing that the only group, by the way, we broke the data down for the first time by race and ethnicity, the death data, and found that the only group that was still seeing an increased rate of death When everybody else's was coming down was our Black population. And then when we further broke it down, we saw the only group still seeing an increase in deaths in Massachusetts was Black men. And that really allowed us to change our focus and, again, take action and divert some of our federal funding to communities of color. The other groups that were highest risk in this were individuals with housing instability, individuals with a history of incarceration, those with co-occurring mental health issues, and pregnant and postpartum women with opioid use disorder. And for each one of those areas, we have then done specific programming and policy changes to address that and are now measuring outcomes. So it's about starting with the data and using a precision public health method to really target outcomes. And as we do that, it's very much in line with our work at the Department of Public Health around health equity and giving everybody opportunities for health, and health opportunities being a right for all and not a privilege for some.
Somewhat joked on our first meeting when we brought all 5 hospital systems together that our measure of success is we'd have a second meeting where everybody would show up. I joke, but it's true. I think the last time all the systems came together was actually during a measles problem back 30 plus years ago. And so that was our first measure of success. But I'm going to jump forward to another really measure of success that I believe we've had, and it shows the power of collaborating. Our patients in the community go to all of our facilities. Some are loyal, but they go to all of them. Our nursing staff, our community staff work at all the different hospitals. And we recognized from the very beginning that we were doing great work educating many parts of our community and our healthcare providers. We were doing absolutely nothing to educate our nursing staff, who spends most of the time with the patients, right? From the EDs to the acute care sides, to the ambulatory, how to identify opioid use disorder, how to help manage pain, not just by getting another injection, and most importantly, how to lower the stigma for the nursing staff. We know it happens, right? And so we that was our first really big effort. We got all of our chief nursing executives together. We developed nursing education for our modules, and we've done our initial pilot, shows really positive outcomes so far, and we're now rolling this out. But that is the power of partnership and the power of we were unable to really see that ourselves individually, that we weren't doing that. We now have a really strong message that goes across the entire community to all of our nursing staff. To me, I think we have a lot of other things to celebrate, but that is what I'm absolutely the most proud of at the moment, because our nurses touch these patients so much.
Thank you, Randy.
Randy made the comment about people showing up for meetings, and I want to just follow up for that. So we like to joke in Seattle that prior to doing LEAD, the only time the operational partners talked to each other was when they were in court in front of a judge and being ordered to talk to each other. And so that for us is a huge part of our success now, is that we have frontline police officers, 25-year veterans of the Seattle Police Department, who openly admit they like arresting drug users, who instead of arresting drug users are now calling a harm reduction-based case manager and saying, come and get this person. So for us, success really looks on what sector you're in. For a frontline police officer, success is that person on that corner that you have arrested 56 times. And I'm not kidding. That was the very first diversion we did. This was that person's 57th arrest. Well, it would have been their 57th arrest. So for the officers, it's really concrete. It's like, give me a better outcome than what arrest is giving me, and I will do this in a heartbeat. For prosecutors, it's like, can we divert prosecutorial time to real offenses? Our prosecutors, like, really up front, I'm not going to lose re-election over not sending someone to prison for 5 years for $20 worth of drugs. I definitely am going to lose re-election over car theft. So again, that's that. And then for the community, it's like, people aren't breaking into my cars as much as they used to. They're not sleeping on my loading dock. They're not smoking crack in my doorway. That kind of thing. So each sector has their own definition for success.
That's a great reminder. We want to have multiple sectors with success. And Rosemarie.
I think that's really important, Kris, that depending on what sector you're talking about, the success will be defined differently. So in Rhode Island, what we did with our expansion for opioid use disorder in our prisons was most prison systems and around the country the standard of care within jails and prisons is if someone comes in on a methadone, buprenorphine, or Vivitrol, they are usually tapered off of their treatment. And that's the standard of care. So imagine if you have diabetes, imagine if you have hypertension, and you become incarcerated, and they were to say to you, we're gonna taper you off your medication. Would that fly? Not at all. But because of stigma, because we don't understand the disease of addiction, and we don't understand how to treat these disorders, we withdraw medication, except for the most vulnerable population, pregnant women, right? So if there's a population that we protect, it's pregnant women. We only use the safest practices with pregnant women. Well, if there's a pregnant woman coming into corrections, we continue her on her medication-assisted treatment because that is the best evidence-based practice. Anybody else coming in? We're going to withdraw them from their medication. And just recently, the Academies of Sciences, Medicine, and Engineering they did their own study that was commissioned independently, and they said medication-assisted treatment saves lives. This came out in March. And so what we know from corrections is that people were being taken off of their medication, which was leading to this very high risk of overdose death. So in Rhode Island, we decided that we were going to continue people who came in on treatment. So if you were on methadone or buprenorphine, you were going to be continued on your treatment. We also initiated treatment for those individuals who had opioid use disorder who were appropriate for treatment. So if they came in and they were committed on a Friday or a Saturday, and we screened everyone who comes in on commitment. And if they're appropriate, if they're showing signs of withdrawal, they will be assessed by a prescriber, and if appropriate, offered medication. The determination of the medication is between the patient and the doctor, and they'll be started on their treatment. The most controversial group, of course, were those individuals who were being released. So they've been sentenced and maybe they've been in for quite some time and they haven't been using. We do pre-release inductions onto medication-assisted treatment. What are the successes of this program? Overall, before the program, 60% of our decedents from opioid overdose had a recent criminal justice involvement within the past year. We know that 15 to 25% of our population have an opioid use disorder. A year after we started the program, we looked at risk of death, and we reduced overall statewide the risk of death from opioid overdose was reduced by 12%. Among the criminal justice population, we reduced opioid overdose deaths by 61%.
Wow, that's amazing.
So to have a mortality outcome like that is pretty amazing. But that's a great success in terms of public health. But it's the connection to treatment that makes that work. Because if these people were not connected to treatment, because they can get all the treatment while they're inside, there needs to be that continuing to treatment on the outside. Rhode Island is a unified system, so we have some advantages that other states and jurisdictions do not. And so we've been able to connect people. So from the public health perspective, we've been able to reduce the mortality among this population. From the perspective of the public safety, we're looking at reduced crime, and from the perspective of inside the facilities, we're actually looking at a better managed population. And our wardens are telling us that they're seeing that people are more engaged in what's offered within the facility because they're not sick.
That's great.
And they're able to engage in what's offered. and they're engaging in treatment and other programs while they're inside.
Oh, what a great story, and I love that you've been monitoring multiple sectors, the successes in multiple sectors. You know, one of the things that sometimes happens at a summit like this, and particularly where we've got people who've been able to do remarkable things, is folks in the audience may think, oh my gosh, that's like incredibly wonderful. I don't know if I could do that. My environment's complicated. You're talking about these successes. They sound like they were easy. So maybe I'd ask you to tell us just maybe in any one of you that wants to share a challenge that was faced where maybe it wasn't such a good outcome, or you were able to work on that challenge, but it really took some work and some attention, not so easy, to give a little bit of a sense of this work takes time, this work takes energy, and you face bumps in the road and you're doing it. So any order at all.
For us, the challenge is a systemic one that all of y'all are going to be familiar with. So for us, housing is a huge issue. Seattle, we were actually an outlier for a while. 82% of the folks that were being diverted in were unhoused at the time of their diversion. In some of the areas we're working with, for example, like Los Angeles, Honolulu, it's close to 100%. 56% of our folks do not even have legal identification at the time that they've been diverted. Sometimes they haven't had legal ID for 20 years. And you think getting legal ID is easy? No. Getting someone legal ID when they haven't had it for a long time takes weeks and weeks and weeks. You can't get that person into treatment without legal ID. You probably can't get them consistent medical care. You can't get them enrolled in Medicaid. Our Social Security office in Seattle, you have to have legal ID to get into the office. So, I mean, the system barriers are the hardest thing in the world. And so that's what our case managers spend a tremendous amount of time doing. And what's been interesting is that, it's so frustrating for the police officers because they were not aware of this. The police officers, before we did this, they thought that services were available. They thought that if someone wanted drug treatment, they could get drug treatment. And so our officers are actually the ones coming up with creative fixes. When they discovered the issue of legal ID, they went to the jail and they got the person's booking photo and gave it to them and said, you now have government-issued ID. Take this to the Department of Motor Vehicles and use it. So, that's what we struggle with.
And we had a lot of different challenges in getting our group together. One was, as I mentioned earlier, just getting folks that are competitors to the table and staying to the table. We had the challenges of, we were all doing really good work in our institutions, but we were doing different work. And so everybody had their pet projects. And in order to be at the table and stay at the table, they really wanted to see their pet projects taking off. Yeah. And we wanted to, in order to keep people, we wanted to invite everybody. And once you invite 5 people from university hospitals, you have to invite 5 people from each of the other hospitals. Now you got, right? I mean, do the math. Pretty soon we didn't have room big enough to invite everybody that we wanted to invite. And so the pet projects and inviting everybody and trying to be for everybody quickly found out that we were losing interest very quickly, and people did not feel like they were part of something larger. We quickly really then decided that we, for better or worse, and this is no offense to the non-physicians in the room, we just said, look, we're going to take the physicians from each of the organizations, 5 of us, I'm going to chair it, and we're going to come up with an outline for a strategic plan, and then we're going to invite everybody back and work on it from there. And that worked. We developed a 3-year strategic plan with real goals, real objectives, real owners, and real opportunities. We did keep some pet projects in there because they were going to elevate all of us, but it wasn't just for one group. And we really concentrated ourselves down and then got ourselves really working. So we stepped back, we concentrated our efforts, we got our leadership, we met people where they were, many times, but we also had to say, look, this is what's going to do the best to get us together, because this is ultimately for the community we all live in and serve in. And so our challenges early on were figuring out how to do that, how to get all the systems working together in a really harmonious way that was interested in moving forward on what our community needed.
When you're working on projects of this scope, you still have to have forward movement, and there has to be a plan, but at the end of the day, you have to have progress. And so one of the challenges that we faced in Rhode Island in our DOC system was that we wanted everyone's buy-in, and we wanted everyone's cooperation, but at the same time, it had to happen. And so when you're surveying and getting everyone's input, sometimes that can be unsettling, and you can just keep taking steps backwards because you can't have a plan that's very tenable. And so one of the challenges I think that we had were the competing missions. So with Department of Corrections and our security officers, their mission is public safety. And that is what they're about. That's what they're paid to do. And our medical director at the Department of Corrections, her mission is health. So it's really interesting when you have these competing missions and how are we going to achieve the same goal. And security doesn't want to hear that we're going to be forming new medication lines and moving 120 people all at the same time. And they certainly didn't want to hear that I was going to be bringing in tablets to screen people for opioid use disorder. I was going to bring in these nice tablets. Everything was going to be programmed. And I thought it was a great idea, by the way, because I wasn't going to bother security. I was just going to have people all come into the same room with these tablets and do it themselves. Very, very naive of me. So it was, the lessons, the challenges were coming together on the same page and coming up with a new unified mission, which is to keep people healthy within the mission of the DOC, which was public safety. And so that's a very, it was quite challenging, particularly with security. When we first started, we had patients that were in med lines and would say they wanted to come off medication because they were being hassled. And they're like, nope, it's just not worth it to me. I'd rather go through withdrawal than deal with a strip search. And so we had to kind of go back to the drawing board. Okay, so we need to deal with security in this facility. We need to educate them. We need to talk with them about how they're interacting with patients. And those things are challenging. And I don't have any street cred when it came to that. I'm not a correctional officer. I don't work with security. So I had to build a relationship. I had to build trust. And we needed the people on the inside to be our champions. And we were able to do that, but it took time, and there were a lot of mistakes made. And then you need to say you're sorry and apologize. This didn't go right. How could we do this better? We need to meet people where they're at within the confines of what the mission is. Because at the end of the day, the governor said, we're going to do this. The director of the correctional system said, this is going to happen. So let's write the story together rather than them tell us how this is going to happen. We want everyone to be part of this. Let's write the story together.
So one of our biggest challenges, which anyone in the field, this will be familiar to you, this remains the biggest challenge in my mind, is stigma. And lots of folks have touched on this before. But there's, in so many aspects of this work, we know what to do, right? We know if we infiltrate communities with naloxone and everybody carries Narcan, the death rate goes down by 45% in models too. We know that if the people who need medication get it with the appropriate counseling and guidance, that the deaths go down by 50%, right? So you have the data behind it, but the stigma is about the bias, and bias is about unknown. And until recently, many folks never saw people successfully in recovery because people were very quiet about their successes in recovery. So, to me, the challenge of that is about having, being a data-driven, science-based person, having to be patient, having to take the time to build the relationships, to introduce the folks who are in recovery. I'm very proud of a campaign we did called State Without Stigma, which is all about individuals in recovery. You can watch short little videos of them, and we've spread that out and have champions in almost all communities in Massachusetts who are champions for State Without Stigma. But that takes time and effort, and right, in approaching something, I usually come in full bulldozer ahead because there's a lot of work to do and you have to do it fast, but this is about taking a step back and seeing it, like you said, from their point of view. And in our criminal justice model, which we are modeling after the amazing work done in Rhode Island, for our criminal justice colleagues to say that, we want you to treat with medication for opioid use disorder because it's going to cut the Medicaid cost, and the person's not going to, then when they're outside, they're not going to have medical issues, right? How does that resonate? Yeah. So talking about, how it will help them with their work and the frustrations that they have with their daily work about detoxing folks and about trying to do the warm handoffs after, and by the way, their recidivism rate, right? That kind of stuff resonates. So really, I think it's about the patients, and I know you wanted one, but I have to say that I think this group will appreciate, I have two more quick ones. It's really hard for us in public health to make sure there's an emphasis on prevention, right? Because we're counting things, we're looking for outcomes, and we really, this work is about prevention, and as much as we have to continue this effort to make sure the work is happening with the young people. All of these initiatives, whether it's the vaping and tobacco stuff that the Surgeon General spoke about, whether it's the suicide rates, resilience building, we have to connect it all, because otherwise this moment will pass and we won't have done the prevention work that our young people need. And the last one is around the way our funding streams work. So as we do work together across different sectors, you kind of alluded to this, each one of us has a different grant with different outcomes and different definitions and different subgroups that we're focusing on. When we come together and try and do the work together, it makes it harder because the funding is so siloed within our own work that it's hard to then come together around the person who needs the help. So more thinking about the funding in more creative ways at all levels, I think, is important.
Thanks. I think what you've illustrated is you can have a success. You can overcome some of the barriers, but it's not simple, and it's not. Once you've overcome some of those, then all the problems go away. There are a lot of things to continue to work on, but you can have successes along the way, which I think is important. So we want to open things up now for questions and comment.
My name is Maribel Bricenio. I am a prevention coordinator.
Yay.
And I just want to make a comment. I want to thank Dr. Monica Bharel, I hope I say it right, for your statement right now, because we do need a lot of prevention efforts out there. We have a lot of prevention efforts out there, but we need more of exactly what you just mentioned. We need to have universal prevention. We need to have those funding sources. I also oversee the outpatient treatment services of the organization that I work for, and I'm at Phoenix House in Los Angeles. And I see exactly what is needed there in terms of how we proceed. I also want to say to Kris, thank you for sharing your experiences, because something so small as an idea affects all of our youth as well, especially the ones that I see now, which are the transitioning age youth. My younger high school students, to the surgeon, thank you so much for making this statement about how our new generation is looking at marijuana as less harmful. And I see that with my high school students that I work with. I have two of my prevention specialists somewhere around here, but they see a lot of that and they hear a lot of that at the high schools that we're at. We're having to drop down the age in which we're doing prevention work in, which is now at the elementary level. Mm-hmm. So thank you.
So thank you. I think what you're saying in terms of the intersector work is working in the education system is very important, working in the schools and working with young people.
Hi, my name is Sir Duplashawn with the Institute of Public Strategies. And my question is to Kris. You alluded to the problem of dealing with the homelessness and dealing with the housing. How are you guys able to deal with it? Because that's a barrier that we can't seem to overcome.
It varies so much from jurisdiction to jurisdiction. I mean, a couple of the places that we're working with have dedicated a lot of money specifically to housing, and they really are operating on a housing first principle. Mm-hmm. And getting people into housing is a top priority. Seattle, it's an abysmal failure. We need 14,000 units of housing yesterday. And so that is the biggest issue that we're struggling with. And I'll just say that, I think I was a little naive when we started this about how we would be able to address it. And I was spectacularly naive about how bad the housing issue is coast to coast. I'm a city person. I've always lived in cities, and so I have urban bias. And I thought that people out in the countryside lived nice, bucolic lives and that they would never deal with homelessness. I knew they had poverty, but I didn't realize the extent of rural homelessness. Homelessness is a public health crisis in this country.
Do you guys have a Band-Aid to go over until you get the people into homelessness?
Sure. So our case managers do an awful lot of that. They do try to get people into shelters. We opened up, sort of replicating some of what happened in San Francisco. We've opened up navigation centers where people can stay for 3 to 6 months. It's not housing, but it's a place where they can stay, and it's open 24 hours a day, unlike shelters, which kick people out at 6 a.m. and don't let them back in until 9 p.m. There's a lot of Band-Aid solutions that are being done. Some of the more robustly funded LEAD projects actually try and purchase housing for people rent on the open market. Seattle, it's just not feasible to do that.
In my time at Boston Healthcare for the Homeless program, I was there for 12 years, and we dealt with these issues for a lot. At the state level, I can tell you some of the short-term things that we're doing is the residential recovery is really being emphasized for individuals with histories of housing instability, and part of our Medicaid 1115 waiver is now for the first time paying for some of the services in residential recovery, so that allows to sustain that a little bit more. We also work very closely with in our big cities, such as Boston, the engagement centers, and other areas where we're doing direct outreach onto the streets to engage individuals in treatment in ways they can accommodate. I spoke earlier about private-public partnerships, and one of our largest privately funded partnership is with vans that go out, and actually on the van they provide on-demand, outside Suboxone induction and other introduction to medications, so really trying to engage more. I will say that, this issue of housing, we all know that recovery is impossible without stable housing. So I ask us all to think about what levers you have within your own system, because it is multiple sectors by definition to get the housing. And just to give you a quick example, at the Department of Health, we oversee our healthcare system's community health investments. So it's sort of like the community benefits that many non-for-profits have. And we, for the first time 2 years ago, stated state priorities, and that funding must now go to one of 4 areas, including housing, instability, homelessness, addictions, mental health issues, or preventable chronic disease. And one of the first institutions, one of our urban hospitals, Boston Medical Center, for the first time invested their community health investments in actually building a housing project and then supporting a grocery store within that. So just thinking about what levers each of us have and how we can start to slowly push the work forward.
Okay, now you experience the frustration, because I think there's some additional questions, and opening up the question about housing, I think, as a key sector for which there needs to be cross-sector work is just one example, is that as is working with schools.
Erin Haas. I run an office dedicated to harm reduction services at the Maryland Department of Health. I have a similar question. It's just about how you involve nonprofit organizations in your coalitions or as partners in this work, particularly those who represent the voices of people affected by the programs that you're implementing.
Say more about what you mean by a nonprofit when you're saying that.
Community-based organizations. So I know a lot of the work that you're doing involves other sectors that we're familiar with, public safety, social services, other government organizations. And so I'm just wondering how nonprofits, particularly smaller nonprofits who might be more connected in the community or working with people upon release, are kind of included in the planning.
Yeah, sure. I'll just start and say that in every one of the jurisdictions that is doing LEAD, the service provision is done by a community-based non-governmental organization. That's not a requirement, but that's just the way it's worked out, and I think it's more effective that way. And we also do a lot of community outreach and community engagement, so that voices of affected communities are at the table. And we try to make sure that happens in the places that are doing it.
Before we started expanding our medication program within DOC, we made sure that there was community capacity for continued and continuum of services with the population. So we reached out to behavioral health and substance use providers throughout the state to have their buy-in and their agreement that they would provide services to the population after release, because there was no point in setting people up for failure. So we needed to make sure that there was a continuum of care and that we had capacity across the state in terms of methadone, office-based buprenorphine, and mental health services. So we laid the groundwork with those agencies before, and with our state behavioral health. They were on board right from the beginning, so that we had that capacity and people could have their services.
Just to add to that, community engagement is the core to all of our work. Nothing happens if you don't have local engagement. In the example I gave earlier about the community benefits funding, we actually baked into our regulations a definition of community engagement, and each year the healthcare systems have to report back to us in writing on how they engage the community following national standards. One example, our syringe service programs, you mentioned harm reduction, are all locally run and get local Board of Health and municipal support for that work. All of our commissions have people either who are actively using, we had a harm reduction commission recently that had active users on it, or people in recovery, and we really focus on our peer-led work as the cornerstone of our work. Thanks for raising it, it's really important.
You will be hearing from some of the speakers later in the day. They're going to be on other groups and sessions. In addition to that, please feel free to approach them if you don't mind my saying that, those of you on the panelists, and just continue. This is a discussion that should be continued throughout the day and beyond today as well. But I think you will join with me in saying what incredible work these 4 people are doing, and thanking them very much for their participation.